Good afternoon, everyone, and thank you for joining us for the Pearly Health Center of Excellence webinar series. My name is Atul Jaiswal, and I'm the research lead at the Pearly Health Center of Excellence in Frailty Informed Care. Pearly Health is a unique and innovative campus of care, home to more than 600 seniors and veterans living in independent apartments or receiving long-term care. Pearly Health is also a center for research, education, and clinical and therapeutic services. The Pearly Health Center of Excellence leads and participates in innovative initiatives, research, and knowledge transition activities that help advance quality of care for older adults living with frailty. Before I introduce our speakers for today, I want to let people know that there'll be time at the end of the presentation for questions, and you can do so by writing them in the Q&A box at the bottom of your screen. Feel free to enter your question at any point of time. Please also note that today's webinar will be recorded. You'll be able to access this recording as well as the past webinars on the Center of Excellence webpage. Once the recording is available, we'll share the link with all attendees so you can revisit the webinar at any point of time. We also ask that you take a minute or two at the end of the webinar to complete the short survey that will appear on your screen when you exit the webinar. We are very fortunate to host Dr. Amishu and Ms. Seles Yung for our webinar today on the topic of shifting needs in Ontario's long-term care homes. Dr. Amishu is an investigator at Pearly Health and a lecturer in the Department of Family Medicine at the University of Ottawa. She also holds the U Ottawa Brain and Mind Breer Health Research Institute Chair in Primary Healthcare Dementia Research. Her research uses population-level health administrative data to examine older adults' health and healthcare needs, especially in those living with dementia and individuals needing long-term care. Ms. Seles Yung is research coordinator at the UBC Center for Health Services and Policy Research. She primarily conducts health services research among older adults and those residing in long-term care. Without further ado, please welcome Dr. Amishu and Ms. Seles Yung. Over to you, Amy.
Thank you so much for the introduction, Atul. Welcome, everyone, and good afternoon. First of all, I just want to thank the team at the Public Health Center of Excellence in Frailty Informed Care for inviting us for this talk. We're really excited to have the opportunity to share some early results that we have around the project where we're looking at the changing demographics and needs of long-term care residents in Ontario. So the presentation today will cover a little bit of background and rationale for the research. We'll present our study aims and methodology. We'll switch over then to Seles, who will present the results of our analyses, and we'll have some time towards the end to discuss implications and next step in our work, but also leave time for questions and discussion. So to start, I think this is not new information to anyone on this call today. I imagine many of you are involved in long-term care, whether as a provider, potentially as a resident, maybe looking after, or a family member looking after someone who is in long-term care, or someone who works within long-term care, whether as a clinician or a researcher, that there is increasing demand for services that are provided in the setting. And a lot of that is attributed to the growing proportion of older adults, so individuals over the age of 65 in our population. And more importantly, there is a growing number as well as proportion of individuals over the age of 85, both in Ontario but also across Canada. In previous research that we had conducted, we have generally found that the complexity in terms of the medical needs of residents coming into long-term care has increased over time. So in a study that we had done now about 5 years ago, where we looked at the 15-year trend of newly admitted long-term care residents to Ontario long-term care homes, what we had observed at that time was that there was an increasing proportion of residents who were coming in above the age of 85. There were increasing proportion of residents coming in who are multimorbid, so with 5 or more chronic conditions. We were seeing individuals coming in with greater functional limitation as well as poor cognition. So the high prevalence of dementia in this population is not surprising, likely to many of you. And along with that, increasing proportion of individuals with other chronic conditions as well, including hypertension, diabetes, uh, osteoarthritis, but also CHF. Now, we also know over the past few years, long-term care was one, significantly affected by the COVID-19 pandemic, but also a number of policy changes that has really affected who is receiving care and how we're delivering care in this setting. And so one of the rationales for doing this research is really to see how this population has impacted by the multitude of external factors, both in terms of the pandemic, but also policy changes that we had seen. One of the reasons why we think these changes have occurred is, for example, in terms of the earlier phases of the COVID-19 pandemic, we do know that individuals who are older, multimorbid, were more likely to be affected by COVID-19 in the pre-vaccination era. So we did see higher counts and proportion of premature deaths and also chronic illnesses that came out of COVID-19 infection. So individuals who are really high risk, likely older and more frail, were more likely to be affected by COVID. And so that has affected their mortality rate and life expectancy within long-term care. As I mentioned, there have been policy changes. Some of them started even prior to the pandemic that has affected how long-term care is structured and delivered in our province. One of the things that we know that has really, I think, started to kind of take place over time is a gradual elimination and removal of the ward type rooms. So the multiple bed, 3 to 4 bed shared accommodation within long-term care. But also more recently, we know that with the introduction of Bill 7, there was increasing pressure to alleviate the wait time in hospital by discharging patients earlier into other settings, including long-term care. So the combination of, going through the pandemic, changes in that demographic, but also some structural changes in terms of the long-term care bed availability, and also the competing demand with more and more discharge coming from the hospital has potentially had an influence in terms of who we're seeing in long-term care now. And that's what this project set out to explore. So our study aim was to use population level administrative data, and I'll talk a little bit about what we mean by that, to use this administrative data to provide updated profile information about the care needs of current long-term care residents to support future healthcare and health system planning. And specifically, we looked at the healthcare characteristics of long-term care residents between 2018 and 2023. So the data sets that we use, there were two main data sets. One is called the registered person database, which is really just the OHIP registration data. So anyone with an OHIP card who's eligible to receive services through our provincial healthcare program will have information within that registry. So contained within that would be information related to the individual's age, their birth sex, where they live, which is also tied to their postal code and potentially the postal code of the long-term care home that they're residing in. As well as what we're able to derive from the postal code is to look at the socioeconomic status and the income of the individual resident prior to coming into long-term care. So it gives us a perspective around who is receiving care and whether there might be inequity to accessing long-term care based on your socioeconomic status. So all that information is actually derived from the OHIP registry. Other information that we have used in this research comes from the RIE-MDS. So some of you might be familiar with the RIE-MDS. It's a comprehensive health assessment tool that is used in the long-term care environment upon admission into long-term care, but also annually as well as quarterly to capture information on the health status, the functional capacity, as well as some measures of healthcare use in the among long-term care residents. So healthcare use, health status includes some of the comorbidities I presented and mentioned earlier, but also actually a much longer list of conditions that long-term care residents experience. Cognition and functions are measured through a variety of scales that is captured, that's included as part of the RIGHT MDS assessment. And then healthcare use, some of the preliminary measures that we have included are things like hospitalization, the number of medication that the person might be on, and it does actually contain information about the types of medication as well. So those are the data sets that we had utilized for this research. As I mentioned earlier, we really focused on the population who were in long-term care at some point between 2018 and 2023. In this case, we use fiscal years, which starts on April 1st and ends on March 31st of every year. And then we basically looked at prospectively over time what happens to individuals within long-term care and who is coming into long-term care. It's what's called a serial cross-sectional study. So basically, every quarter that the assessments are performed, we take a cross-section, we take a perspective, one point in time perspective to look at who's in long-term care at that time and then what their outcomes are. So the first thing that we'll highlight is actually to look at the trends in terms of the number of admissions and the number of individuals who are in long-term care. You'll see that, and this is actually a number that is widely available through public sources, that typically, and before the pandemic, we had close to about 80,000 long-term care residents in the province. So this actually accounts for the fact that it's not 80,000 beds, there's turnover within those beds. So it does account for that turnover within long-term care. Of course, during the pandemic, there were significant changes in terms of the number of people receiving care, but also the number of individuals who are coming in. So you'll see in that April to June, that first wave of the pandemic, the number of admissions really declined in long-term care. Much of it is attributed to the fact that we were trying to prevent the spread of SARS-CoV-2, especially to this population. So the number of admissions were limited at that time. It did steadily increase over time over the course of the next year, but it didn't really quite resume to pre-pandemic levels until the vaccines were available towards the end of 2020 and early 2021. So that's when you see that dip in terms of the number of admission in that dashed line at the bottom of this graph. The solid line at the top of the graph represent the total number of individuals. What's interesting is that when you look at the dashed line, so that represents the number of new admissions coming into long-term care, it has more or less resumed to pre-pandemic levels. When you compare the number in 2018, which is just over 7,400 individual per quarter, now it's close to, well, in 2023, it's close to, we're just slightly over 72,000 individuals per quarter. What's really interesting is that when you kind of compare the total number of residents receiving care, the number hasn't increased as much as the number of admissions. So what that suggests is that even though we are nearly admitting just as many residents into long-term care, there are more individuals receiving care in the setting. And part of that was attributed to what I pointed out earlier, that over time, there's focus on redeveloping some of these beds, so converting the ward rooms or the share accommodation into more semi-private rooms or private rooms within some of the newer facilities. So there are actually fewer beds that are available within the province. And part of that is also that the pace of building the construction of these new facility has not kept pace with the demand that we're seeing within long-term care. So over time, we're actually seeing fewer and fewer spots. And there are implications because even though we have the same demand, and then again, the demand coming in from more residents being transferred out of the hospital, it actually potentially has increased the wait time for individuals waiting for long-term care placement in the community because we are not having more beds, but then more people are coming through in the hospital. So that there are some implication in terms of how that's shifted the care needs and the profile and the care characteristics of people in long-term care right now. This is just an overview. This table is an overview of the baseline characteristics in 3 different periods. So a little bit pre-pandemic, in that first phase of first year prior to the pandemic, and then also the most recent year of data that we have access to in 2023, you'll see a slight decline in the average age of assessment, which we'll go into a little bit earlier, which really shows you that individuals coming into long-term care are gradually becoming younger than what we've seen previously. There are also lower proportion of female residents coming into long-term care. In terms of the rural facilities, part of this is a reflection likely of where the redevelopments are occurring. So there are fewer individuals in rural facilities than in urban centers. Overall, in terms of socio-demographic characteristics, you'll see that it hasn't really changed in terms of who is accessing long-term care. Historically, we have always have seen that individuals from lower income quintiles, so lower income brackets, tend to require more likely to require publicly funded services such as long-term care, more so than individuals from higher income brackets. In terms of multimorbidity and the conditions, these scores are the average, and we will actually dive into, so Seles will actually present the trends across each of the conditions. And this is where we kind of see some really interesting trends in terms of when we kind of look at what happens when you have a younger cohort and the conditions that they're coming into long-term care with, you'll see kind of changing in the directionality of some of those conditions. So I won't dwell on the comorbidities because we'll dive into that later on. But what you do also see is that there is actually kind of continues to be increasing um, cognitive impairment as well as functional impairment in this population. The cognitive performance score basically just the average score of the level of impairment. And basically higher score indicates greater cognitive impairment. The activities of daily living score is a functional score, so it measures a person's ability to carry out daily activities, things like bathing, maintaining hygiene, meals, as well as mobility. So we do see that increasing cognitive impairment as well as physical impairment among residents coming in. So over time, as I mentioned, as you saw in that average age trend I showed earlier in the table, over time, we're actually seeing a slight decrease in the number of residents who are coming in above 80 years of age. So the top line, the green line, is the trend among those who are 80 to 89. The purple line are individuals who are 90 plus coming into long-term care. And you'll see that progressively over time, the proportion of residents who are 80 plus has declined in our long-term care homes. And this is across the entire province. And the group, the age group that's really increasing within the province are individuals who are between 65 to 79. So for lack of a better word, I think we often refer to this group as the younger seniors. So that population increased by almost 4%, which 4% doesn't seem like a large change, when you're kind of looking at the proportional changes. But when you apply that 4% to 80,000 individuals or 80,000 residents or beds within the province, that basically converts into about 3,000 residents over this time. So you're seeing these shifts and their implications in terms of when you have a younger senior populations coming into long-term care, what does that mean in terms of the care needs? And do they look like the seniors who were previously coming into long-term care pre-pandemic? Now we're going to try to make this a little bit interactive. So if you have a phone, if you are sitting in front of a computer, we encourage you to log into this link, this Mentimeter link that's provided here and also in the chat. So the question that we are asking is, what do you think are the most common health conditions among long-term care residents? So I'll give you a minute to maybe log in, and I'll switch over to our page where we're showing the word cloud. Okay, so link is available in the chat if you are looking for it, and I will switch over. Okay, so we're seeing a lot of input. Dementia, I think, is mentioned quite a bit. CHF, diabetes, a lot of these we mentioned. Social isolation, great. Mobility, cognitive impairment, yes. So a lot of things that I had alluded to early on. Okay, it seems like we're not getting any. Oh, we are still getting some additional input. Okay, that's great. So now we'll see whether these responses align with the data, um, the administrative data that we looked at. Salas, I'll turn over to you.
Thanks so much, Jamie. Can everyone see my screen? Okay. So I think a lot of these responses we saw on the word cloud. So like your responses, dementia, hypertension, which isn't shown here, is also one of the most prevalent conditions, diabetes, stroke, etc. So here we presented the prevalence of some of the top conditions among long-term care residents over time. And so we've seen a slight decline in the prevalence of dementia from around 68% to 65.6%. We see sort of a larger decrease in arthritis from just over half of long-term care residents to just over 40%. Similarly, we see slight decreases in the prevalence of both depression and stroke, while diabetes has remained relatively steady. So when we first looked at these trends for the entire study population, they were kind of unexpected for us. We didn't expect to see this decline. And so we realized that we had to do a bit of a deeper dive. And so, as alluded to earlier by Amy, we thought that we should stratify by age to understand these trends better. So just to orient everyone to these graphs, because they're going to be the same for the upcoming slides, we've presented prevalence by age group here. And the four age groups are below 65, 75 to 79, 80 to 89, and 90 plus. And this is the prevalence as a percentage of the age group. But at the bottom, the two boxes will show the total number of residents with each of these conditions at the first study quarter, which is April to June 2018, and then the last quarter, which is January to March 2023. So as we can see here, dementia, the prevalence overall has decreased from around 54,000 people to 49,000 people over time. But when we look at the breakdown by age, we see that the rate in the two oldest age groups, so basically those over 80, are relatively steady. But there is a decline in prevalence rate in the two younger age groups. So that combined with the fact that actually the total number of those in the two older age groups is declining, that will help explain why the total number of people with dementia in long-term care has declined over time. Next, looking at hypertension, which is also very prevalent in long-term care. It's decreased slightly from around 54,000 people in 2018 to close to 50,000 people in 2023. But overall, the prevalence rates by age group have remained relatively steady. So again, it's because the total number of people in the older age groups has declined that we see the decline in overall numbers, even though the rate remains relatively steady. Next, if we look at stroke, which has decreased from around 19,000 people to around 15 to 16,000 people over time. We see that for most of the age groups, there is a slight declining trend in prevalence rate, except for the youngest age group. So those below 65, we actually see an increase in the prevalence rate of stroke. Next, looking at coronary heart disease, it's declined just very slightly from around 14,000 people to 12,000 people over time. And we do see that this decline is consistent throughout all the age groups. Next, looking at congestive heart failure, CHF has declined slightly from 10,000 people to 8,500 people over time. And this decline is most noticeable in the two older age groups, so the purple and the green line, that was over 80. Next, looking at diabetes, we see a decline from slight decline from just over 23,000 to 22,000. So pretty steady over time. We see sort of a steady trend in the three older age groups. And again, it's that increasing trend in the youngest age groups of those under 65. And then looking at osteoporosis, which has declined from around 27,000 people to over 22,000 people. Here, I think we see a pretty clear decline across all the age groups. So here, I think just going over some of the most common conditions in long-term care, I want to pause and kind of poll everyone to see if, the trends that we've noticed in terms of decline in some of the most common conditions in long-term care, are these trends something that you've observed in your own? Jenna, can you pull up the percentages or the answers? Okay, so I guess we see out of the people who did answer, kind of an even split. Maybe we'll give it a minute more. Okay, thanks for participating. So now we'll move on to some mental health conditions, the most prevalent of which is depression. So here, depression has decreased from around 30,000 people in the first study quarter to over 26,000 people in the last study quarter. And the trend is pretty consistent across age groups. We see a slight increase up to basically 2020, and then from 2021 onwards, there's a pretty marked decline in depression. The second most prevalent mental health condition that we can measure is anxiety. And here we see a pretty noticeable increase in prevalence from around 12,000 people in 2018 to over 14,000 people in 2023. And that trend is consistent across all age groups. And here I want to note that we were pretty surprised by the divergence between depression and anxiety because these two conditions tend to co-occur together, but obviously we're seeing pretty different trends across the two conditions. And then here, we'll focus a bit more on a more rare mental health condition, schizophrenia, where we see it affects a lot fewer people, but also that the trend is the rate is much higher in younger age groups than it is in older age groups. So sort of different than the previous trends we've been looking at. It has increased from around 3,500 people to 3,600 people. And we actually do see an increase in the two youngest age groups, whereas the two older age groups has remained relatively steady over time. And finally, we looked at bipolar disorder, which increased from around 2,400 people to 2,500 people. Again, low numbers, but it does echo the trends that we saw in schizophrenia, where we saw a rise in the two younger age groups. But perhaps because these are much smaller numbers in comparison to the entire long-term care population, the overall impact of these trends might not be as noticeable. So just to summarize kind of all our findings in a few key messages, we see a rise in younger long-term care residents. And that has implications for the shifting care needs. So we saw that there was a slight decline in some conditions that we traditionally linked to long-term care, like dementia and stroke. On the other hand, we see a rise in some mental health conditions, all of them except for depression, basically. So in the context of the existing literature, which is a study that Amy had mentioned at the beginning of the presentation, which looked at admission trends from 2000 to 2015, we see that some of the trends that we observe are actually a continuation of those admission trends. For example, in terms of a slight increase in functional limitations and a decline in stroke, those were already happening prior to 2015. However, our research has indicated that there are some new and emerging trends, or that some of the previous trends have actually reversed. So a decline in dementia and osteoporosis, where they had previously been increasing in prevalence in long-term care. But I do want to note that there was the difference between that previous study and our study is that their study had focused on admission trends, where we focused here on the entire long-term care population. So there is a slight difference. And obviously, the findings that we've observed here have important implications for long-term care. So first, while the study we described today was just a descriptive study where we just observe these trends, we can't really explain why these trends are happening. But given our knowledge and our background in long-term care, we know that everything in the healthcare system works as a system. So changes and things that are happening in one part of the system will have an impact on other parts of the system. So here, for example, the shifts that we are seeing might have arisen due to gaps in other parts of the system. So for example, it's been very well reported that there are a lack of mental health services in the community. And so people who can't access it in the community might turn elsewhere to access it. For example, we hear a lot about the emergency department. So we might also be seeing some spillover effects onto long-term care. And next, we want to talk about kind of these implications for the future of long-term care. So if these changes that we've talked about today are long-lasting shifts, then policies and practices will need to adapt to these changes. For example, we observed a rise in younger residents, and so these residents will tend to have a longer length of stay. That might mean that more long-term care capacity is needed. So obviously that has implications for government projections for long-term care demand. And next, kind of our research has highlighted some changes in the types of care needs that are arising in this population. For example, a rise in mental health care needs. So that might mean that additional training for long-term care staff is needed to meet these other types of care needs that were previously not anticipated. So some of our next steps for our team is kind of what we're doing here today. We want to discuss and engage with long-term care stakeholders about these findings to see if what we see in our research is something that resonates with their experience. And also, it'll help us gain some insight on why we're observing these trends. Next, we're also interested in focusing on specific subgroups and doing some stratified analyses to focus on equity dimensions. For example, we've kind of started a study that echoes a study we've talked about on the Chinese-speaking long-term care resident population. We know that there are also some large linguistic groups like French-speaking, Italian-speaking that we could look at. Veterans are another population group we're interested in, and we know that are very pertinent to the PERLI. Because we know that some of the requirements for Veterans Affairs funding might have affected how this population constitutes long-term care over time. So we do want to look at some of the changes in that population. We also want to do some stratification by sex in urban rural facilities to see if there are any differences between those. Next, I've already kind of alluded to this, but we do want to understand the underlying reasons for the changes that we see. And investigating these changes might require kind of a sort of different study methodology. For example, qualitative interviews with people who are working and living in long-term care, beyond kind of the descriptive stuff that we've talked about here today. And I think that our research also highlights the need for continuous monitoring of these trends. Obviously, the long-term care population is not static. It hasn't remained the same over time. So we do need to have updated information on the profile of residents and their care needs in order to provide adequate support for them. So I think that's it for us today. Thank you so much for listening. I want to acknowledge the other members of our research team and also our collaborators at ICES. I think we posted our emails here. If there are any questions or follow-up after this presentation. And then I think on the topic of ICES, the data that Amy talked about that we used for this project were supported by ICES, and the study was also funded by CIHR. And then if anyone wants to kind of do a deeper dive on the information we talked about, we have listed some references. And then I think we can open up for Q&A now.
Okay, so I see that we have a few questions that have been submitted. Atul, do you want to read out the questions and I can answer them?
Sure. And also I'll say, like, rest of the audience, if you have questions, please start putting them in the Q&A box that you see, and we'll try our best to cover all of them. So the first question is, thank you. I understand the long-term care population is moving into long-term care with more care needs. Has the funding increased proportionally with the increased medical needs? In other words, now that every resident presumably needs more care, more comorbidities, etc., is the per resident funding reflective of the increased needs?
Yeah, that's really a great question. So over the past few years, there's been some changes to the funding in terms of one, the requirement to have a minimum of 4 FTE per person day, and so there was increased funding to support more staffing in long-term care in general. I will say, the recommendation to increase staffing was something that actually came out of the staffing study that was published pre-pandemic, and as well as work that I had personally been involved in. So the increased staffing was a need that was expressed likely over a decade ago. So we're actually just meeting the recommendation that probably came out back in 2015 in some of the early work that researchers like myself have been involved in. The second adjustment was, of course, the adjustment based on inflation. Quite honestly, I don't think either of these are fully sufficient in meeting the complexity of this population. There does need to be additional funding to possibly increase beyond that. But also that there needs to be more investment into upskilling individuals within long-term care to deal with the changing care needs of this population. And I don't think there has been recognition of that to date.
Thank you, Amy. The next question is more or less related to this, but so Jim is asking, can any of this data be used to push policy change to move funding into home care funding, to better allocate services, to keep person in their homes versus going on to a long wait list for long-term care and or into an underfunded long-term care?
Yeah, I think we probably will all agree that, quite frankly, there needs to be more funding in both home care and long-term care. As I mentioned, with the increasing complexity, there's clearly a need for more investment into more resources, so more staffing, training for long-term care clinicians and long-term care providers. In the home and community care environment, likely if the wait time to long-term care is increasing, individuals waiting for placement are only getting more frail and more complex while they're waiting for placement into long-term care. So of course, there needs to be more resources there as well. I think part of the challenge is that inevitably individuals who are waiting for placement in long-term care are already at higher needs to begin with. And so there is that perpetual question of how long you can actually maintain them safely at home, because the eligibility for long-term care is that they need the support that can't be safely provided in the community. So I'm not sure that it's a substitute, but I do think that probably more resources are needed for both settings.
Thank you, Amy. Next question is, the questions list is increasing. That's very good. Yeah, can you explain a little bit more about why depression has declined, even though there seems to be a rise in social isolation that resulted from COVID?
Yeah, that's actually a really great question. It's a question that we have as well as a research team, and we wanted to bring this to the audience because I think there are likely observation that's happening in your community that we're not seeing. So we were actually hoping for some input. I was surprised to see in the poll that many don't aren't aware of these changes and didn't know which direction in terms of the prevalence or the changes that these conditions are fluctuating in. So I'm hoping the data will be helpful and really help us to explore this more. Quite honestly, I don't know why the trend for depression is declining, especially with what's mentioned around social isolation, but also increasing anxiety. They typically move in the same direction. So it is an interesting one that warrants further research.
I have my own personal question related to the similar. So I could see from the graph that were presented that mental health concerns were rising in younger senior population, like depression, schizophrenia, and bipolar. So what do you think? What's going on there? Any insight from there?
Yeah, I think as Salas mentioned, with the increasing emphasis on reducing ALC bed occupancy, individuals who might be admitted to the hospital, especially in crisis situation for mental health care needs, might be pushed towards placement in long-term care. In fact, if you look at the provincial data, so this is available through the Ministry of Health, they have a dashboard that shows the wait time. You'll see that the wait time for entry from hospital has decreased over the past few years, but the wait time for those waiting in the community has increased. So those who are stable and not quote unquote in a crisis situation, and some of that is crisis situation associated with mental health. So one of the follow-up studies that we are planning is to look at who is coming in through hospitals and what services they were receiving either during that hospitalization or prior to. So it might give us a better sense of whether or not that is, in fact, the contributor to these trends.
I'll also say that one of the variables we looked at that we didn't present here was another scale called the depression rating scale. And in that scale, we actually did see an increase, and we were kind of confused as to why we were seeing opposite trends in the diagnosis of depression going down, but then the rating scale going up. It could be because that scale is looking at symptoms, which might be more sensitive to these, social isolation and things like that, whereas a diagnosis of depression is kind of different, or maybe, yeah. So things like that, we're not sure. It might have something to do with how these things are coded in the RAI as well. So, yeah.
Yeah, I agree. It's a data nuances,
Yeah,
between reported symptoms versus a firm diagnosis. Yeah.
perfect. Thank you. Moving to the next question: what can homes be doing proactively to prepare for the changing needs of the long-term care population?
Yeah, I do think that to some extent, as a researcher, I look at this data as a way of kind of providing, data that helps with our advocacy because I don't necessarily think the government or the public is aware of these changes and how much COVID has affected and continues to affect long-term care beyond just the initial 2 years where we're in the pandemic, because there are these repercussions that we're now starting to see. And like I mentioned, it seems like these are small changes that are trickling in over time. But over time, you're getting, a couple of thousand people who are coming into long-term care who's looking different, quite different, have different needs than what we're seeing even a few years ago. So over time, this is going to shift our system, right? So I do think that one is the awareness of that these are changing. And I suspect long-term care providers are seeing some of these with the newer emissions. Um, we have heard throughout consultation that many providers have noticed they're getting more younger seniors, and kind of taking that information and really think about anticipating that they might actually be staying in that long-term care home longer, as Salas mentioned. So there's some planning there, right? When you're getting more younger seniors, the turnover will be different. The amount of time and the care in terms of care planning that has to be factored into consideration. But the other aspect I think is it's really important, I think, for us to bring this to the attention of our, whether it's local, regional, or national governments, because we actually are doing a similar parallel study looking at national trends, and this is not an Ontario specific trend. We are seeing some similar trends in other provinces, and so kind of bring this to the awareness of our policymakers.
Thank you. Next question: the change in the average age of those moving in long-term care may also affect the average age of their family and friends. What do you think this aspect of change in the people who support the resident means for homes, if anything?
Yeah, I do think, as we mentioned, especially if they're waiting in a community, that also means the care partners for these individuals waiting for placement are also aging, and they might have needs as well. And there's a lot of evidence actually that suggests that, as a care partner is declining in their health, their capacity for caring for the person diminishes over time, and then their needs for support themselves also increases over time simultaneously. And so really that also speaks to the, I think, attention to the needs of the care partners in the community, especially when the long-term care wait list is already quite long to begin with, right? So if you are expected to have to care for the person for, even longer and more extended period of time, there needs to be more support for their care partners.
Thank you. Next question: is there a way to compare the age distribution of the long-term care population against general population or retirement home population?
Yes. So there are, of course, general population age trends are available provincially and nationally. That typically comes from the Canadian Census, and then Statistics Canada do projections in between in terms of the population. So it is something that we have looked at. It is interesting because we do know the proportion of individuals over 65 and over 85 are increasing in our population. Now, with the census coming out, next census coming out next year, we might see some differences attributed to COVID, but generally that proportion is increasing. So that is uh, counterintuitive to what we're seeing with a decreasing proportion of 85-year-olds, right, in long-term care. So that's where we were really surprised when we initially saw these results. There is some data available on retirement homes, and there are researchers within ICS. ICS is a provincial data warehouse that have looked at the characteristics of this population. So that's certainly something that is worthwhile to explore. I personally have not done that myself, but it is possible to look at that age distribution.
Another is a comment. Thank you, comment, for your work. And I'll move to the next question by Prashanti. Uh, do you think that the data from your research could help in providing better care to residents with dementia or cognitive disorder? Could it help increase the funding for training caregivers, specifically for residents with dementia?
Yeah, I think that's really important because dementia remains the most prevalent condition in this population. And I don't think the intention or the inference from this result is to suggest that there should be diminished funding or support for existing prevalent condition. I think dementia, of course, I think is a very important aspect of long-term care. When we presented some of the other trends, it's mainly to highlight that there are some changes and we need to be aware of those changes. But at the same time, things that we're seeing with the mental health condition, whether it's depression or anxiety, that also affects many long-term care residents with dementia. So those are symptoms of dementia, and in some cases, precursors to dementia that could benefit from additional support.
Thank you. Does this evidence support increase in care only or in other areas of long-term care, such as recreation, social work, physiotherapy?
Yeah, I think a lot of these conditions are, I think there are the hard healthcare outcomes when we look at things like diagnoses of diseases and healthcare use. But then there are also other outcomes that are, really pertinent to the quality of life that are sometimes difficult to measure. And there are aspects of interventions that are, not only important for the function of the individual, of the residents, the mental health of the resident, but also just generally improves their quality of life. I personally, when I first started in long-term care, I was a recreational assistant. So I spent several years in a recreation therapy program in a long-term care home in Toronto, and I saw the importance of recreation therapy. Even though it doesn't necessarily increase a resident's function dramatically, it certainly helps with their cognition to kind of keep them mentally active. But at the same time, it also increases their quality of life. And, sometimes we do baking. So who doesn't like baking and painting? And really kind of helps to kind of add that, add to the richness of what we can offer in long-term care.
You. Do you see any differences between rural versus city long-term care home admissions?
So we haven't explored that explicitly. As Celis mentioned, these are some of the subgroups that we are interested in looking at. So thank you for that suggestion. We want to dive into this deeper, and some of the subgroup analyses, I hope, will surface and help us understand these trends better.
Okay, next question. Interesting to see that depression rates are dropping even slightly. Do you think underdiagnosis is still happening, or recent years of awareness raising about mental health issues has led to more reliable data?
Yeah, that is a really great question. I don't think I can personally speak to underdiagnoses of depression within long-term care. I think the challenge in identifying dementia on top of, sorry, identifying depression on top of dementia is a challenging clinical aspect because it is one of the symptoms that you see in individuals with dementia. So it is possible, I think, that there is underdiagnosis. We do see that in the existing literature that people often report depression as symptoms instead of firm diagnoses when they have a diagnosis of dementia. So I suspect that may factor into some of this. I don't think it explains all the full trend that we're seeing in the results here, but I suspect it does have some influence in terms of not being identified as a condition on its own.
Thank you. What is the average length of time that a resident remains in long-term care?
Yeah, it's a really good question. I think consistently we have seen the length of stay somewhere between 16 to 18 months, so about a year and a half within long-term care. Now, of course, as this population changes, that length of time will likely increase. And we are starting to see some of that increase. I know the data is not presented here, but we did have that data available, and we did start to see a little bit increase in length of stay. It is something we want to dive into further, because with our current data, these are cross-sectional perspectives. So one point in time, what does it look like? To actually fully study the length of stay, we have to do what we call a retrospective, so a look back type study, where we look at the time of a resident's death or upon discharge, what was their length of stay. So the current study doesn't quite answer that, but we are hoping to dive into that in the future.
Thank you. Is there a link between the age on moving in and socioeconomic status?
Yeah, that's a really good question. Quite frankly, I don't know. The age stratification that we are hoping to dive into will, I think, highlight maybe those differences. I think from what we know provincially with regards to the population trends, we do know individuals from a higher socioeconomic status and need support they're more likely to afford retirement home living, or even getting some support through assisted living. So they're more likely to remain in that environment longer before entering long-term care. So there are some trends there that we do know that if they are younger, but they have the means to afford either private care in their home or in a retirement home, they're more likely to go into that environment. So I suspect that there is, but we don't know because we haven't dived into this aspect yet. It is something that we're very interested in.
Thank you. Just last two more questions. From your study findings, can you suggest what type of psychosocial caring skills training are most needed for current population of residents?
Yeah, quite honestly, I don't think I'm the best person to answer this. In terms of the data, right now we have a good grasp of these trends. And I think our intention is to take this to our clinician partners and then having them add the richness in terms of what does that mean? What are the clinical implication of these trends on the long-term care population?
What is the last question? Is there a link between the age of moving in and the person being attached? That is having family and friends. Not even sure we have this data other than those residents who are with the Office of Public Guardian and Trustee.
Really great question. So we do have some of this data that is available at the time of placement. So we do know that prior to placement, when they're being considered for long-term care, there is some information that care coordinators capture in terms of their living arrangement, who is supporting them, whether they are living with someone and someone who's able to provide how much care that person is able to provide to this person. We haven't looked into that data, but certainly there is some information available, and it's a really great question and something that we hope to explore.
I also think there's a scale on social isolation that's in the RAI data that is another um, relevant kind of variable that we could look into.
Mhm. Thank you so much. I think, yeah, I think we are very close to the finish line. So I would like to extend our sincere thanks to our presenters for this fabulous presentation. Thank you as well to all who attended today's webinar. We hope you enjoyed it. Please stay tuned for more information on our upcoming webinar in April. In meantime, if you like to learn more about Center of Excellence, our current projects, or have ideas for upcoming webinars, please reach out and visit our website at www.pearlyhealth.ca/Center of Excellence. Just as a reminder, we would really appreciate if you could complete the short survey when you exit the webinar. Thank you so much.